Welcome back, everyone. I'm Tanya Fullwider. My pronouns are she, her, and I serve as the Associate Director here at Mental Health America of Ohio. Again, thank you to Dr. Kennedy and Ms. LaShonda for the incredible first session. It's now time to enter our next session, titled ACES and Race, and featuring the team from the Building Better Lives Initiative. Debbie Jones, Joanna Malachowski, and Jesse Schrader are each members of the BBL initiative at Franklin County Family and Children First Council. BBL aims to provide brain-based trauma-informed content and skills application to all child and family service organizations in Central Ohio. Debbie, Joanna, and Jesse provide training, coaching, and skills application for leaders and service providers in multiple settings, including education, infant and maternal health, first responders, and child protective services. The BBL team is committed to building trauma-competent systems that include anti-racist and equity-aimed practices, policies, and procedures. BBL team, please take it away. Thank you.
All right, get all my buttons clicked here. Well, good morning, everyone. Thank you so much for the invitation and for the time this morning. It really is an honor and a privilege to be able to share with you all this morning, particularly after such an incredible opening session. I'm just feeling very informed, challenged, encouraged, just really kind of pushed forward. So great always to work with our colleagues, Dr. Kennedy and LaShonda. It's just really great to spend that time with you. So we are eager to share some information as well, and we think this is really going to connect really well with that first session and hopefully be informative and valuable for you in your work. My name is Jesse Schrader. We are coming to you from the Franklin County Family and Children First Council. Co-presenting with me is Debbie Jones.
Hey, Jesse, the gray boxes are back on your presentation that we had the last time too. I wondered if you could try to reshare again. I'll do my intro real quick and throw it to Joanna too while you do that. But good morning, I'm Debbie Jones. I am co-deputy director here with Jesse over the Building Better Lives initiative and joined by Joanna. And we are just really grateful to be here. Yep, that worked, Jesse. We're good now.
Hey everyone, I'm Joanna Malachowski. I'm the lead coach on the Building Better Lives team. So excited to share with you today. Inspired, as Jesse mentioned, by Dr. Kennedy and Ms. Shonda's presentation. Before we dig into our content today, we wanted to stop and take a moment to ground ourselves and to really position this work inside of a context, right? So we offer this land acknowledgement, which is adapted from some of the work done by the Multicultural Center at OSU. So please just take a couple of deep breaths. We acknowledge that the land we are meeting on today has long served as a site of meeting and exchange amongst Indigenous peoples, specifically the Hopewell, Shawnee, Miami, Wyandotte, and Delaware nations. We honor and respect the diverse Indigenous peoples connected to this territory on which we gather. We also acknowledge the forced slavery of Black people who built much of what we call the United States of America. Tori has put some resources in the chat for looking up your zip code, your address, and the Indigenous people who occupied the land that we occupy now, whose land it is that we are on. There's another couple of resources on this slide here that you're welcome to explore as well.
Thanks, Joanna. As we mentioned, more specifically from our team, we are coming to you from Central Ohio here from the Franklin County Family and Children First Council. Julie Bizard is our interim executive director. You can learn a little bit more about our agency at franklinfamilyfirst.org. Debbie, Joanna, and myself are part of the Building Better Lives brain-based trauma-informed care initiative. And our session today, as we said, is entitled ACES and Race. we are pretty much assuming that many of you are familiar with the initial ACE study. And so we're not going to spend a lot of time with that today, but to let you know our objectives and where we do intend to go with our time is to really spend a lot of time focusing on the ACE pyramid and increasing our understanding of some of the underlying things that are at play, the mechanisms at play that lead to adverse childhood experiences. We'll also kind of then expand our understanding of ACEs to look at some other particular ACE studies and some other ways to conceptualize early childhood adversity. Then we're going to make that connection and shift into how race-related trauma is a compounding factor, particularly in our current context, in current racial inequities around COVID-19. And then we're going to wrap up with looking at resilience factors, particularly multicultural, diverse expressions of resilience, and make some connections for ourselves as practitioners as to how we can be looking at an expanded view of resilience, just like we also look for an expanded view of ACEs. After we increase our understanding. So that's where we're going in our time today. As we have already been doing this morning, please feel free to put questions and comments in the chat area and in the question and answer, and we'll be following along and answering those through a couple of different times throughout the session this morning.
So as we get started too, we just want to recognize, if you were a part of that first session, Dr. Kennedy and LaShonda also took us through these breathing exercises, these mindfulness components, and we want to offer those same things to you. In this session, we have a couple of breaks built in to do those things and some pause and reflect moments. However, we recognize that at points this may be challenging for a variety of reasons, or you need to step away for other things, right? And so please take care of you. That's what trauma informed is. That's what it's about. And we challenge to move the lens. I believe in the first session, they referred to that as trauma responsive, right? And we see that as trauma competency. So that's more about that application. And we would be nothing if we didn't practice what we preached, right? And so we want to offer that too and make sure that you are taking care of you so that you can be as present as you can. And if that means taking breaks, do that. So this first component is kind of just foundational, it's groundwork. And so it is reviewing the ACES study. And so this is probably redundant. It's probably review. You might know about the study, but we center here because we come back to this study again and again due to its credibility and validity, and it lays the foundation for that expanded understanding of the ACES pyramid, and our growth from the original study has changed. And so we want to offer this to you first. And so thinking back to that original study done by Anda and Folletti, Doctors Anda and Folletti, all the way back in the 90s, I say all the way, like that was such a long time ago, right? But back in the 90s, that study was, it was really unique. It was the largest of its kind at the time, 18,000 participants. And what I want to say here is that a majority of those individuals were white. They were mostly women, and they were largely insured by Kaiser Permanente. And I say that because we know that doesn't speak to the populations that you work with, right? But this study focused with those 10 questions was replicated, has been replicated over and over and over again over these last 30 years with different subsets, different populations, different socioeconomic statuses, different, urban versus rural, like lots of subsets of this, and found the same similar results. And because of that, we come back to this because it is still a credible and valid study. And so in that original study, there was 10 questions in that questionnaire that centered around abuse, neglect, and household dysfunction. And so those 10 questions were really, really vulnerable to ask, but what it signaled to us was kind of around those behavior, those mental health incidences and all of those things. It really centered around those things, and that score of 1 to 10, depending on what that was, what Doctors Anda and Folletti then found from that was a dose response correlation to some really serious health outcomes like heart attack, heart disease, asthma, cancer. But it also found some links to social outcomes too and replications of that study. So things like suicide attempts or IV drug use or risk of living in poverty or lack of high school completion. Lots of those things were outcomes of the study. And so actually wrote an introduction paragraph about this morning for a class I'm doing about the correlation between these serious health outcomes and that dose response and the likelihood that increases with these, because a lot of times we see these health outcomes come out and we treat those things, right, in a postvention way. But what we're trying to contend here is that working with ACEs is the preventative. We would then be working with the cause instead of treating the symptoms. So the symptom instead is heart attack or heart disease, which is a little bit of a different shift, right? That's different because that feels like the thing, but that's the postventive of somebody who's faced a lot of adversity or had a lot of experiences that correlated with these original 10 questions, or in the several expansions. We're going to get into the Philadelphia Urban ACEs a little bit later, but the culmination of those things leads to these outcomes. And so what we'd rather do is work to the preventative. And we would be really remiss if we didn't then talk about our ACEs pyramid and how our original understanding of this study has changed since the 90s. And I believe Joanna is going to take us through this section.
Yeah, thanks, Debbie. Hopefully, I've switched my headphones. Hopefully this is a little better for those of you. And disclosure, my 3-year-old is currently quarantined. Her classroom has COVID. So we have potentially some background noise happening here that we'll try to keep to a minimum. As Debbie was talking about the ACEs study, we are typically used to thinking about that as the base of this pyramid, right? And the things that proceed from that through our life. And what we're noticing now, and this kind of the growth edge of this research, is considering below just those adversities that folks experience in childhood, what is actually setting the context? What are the conditions in which those adverse childhood experiences are taking place? So if you look at that next layer down, that social conditions and local context, those of you who maybe have some familiarity with public health might be used to this idea of the social determinants of health, right? And what we know from the World Health Organization is that only 36% of our health is actually based on individual choices that we make. The rest is really determined by these social factors like our physical environment, the access we have to medical care, what the social circumstances are like that we're growing up in, and our genetics and our biology. Even below that layer of social conditions and local context, when we start to talk about this generational embodiment and historical trauma, this is when we're getting into this idea of epigenetics, right? And so we're talking here about trauma that is experienced in the body, and much like Dr. Kennedy and Ms. LaShonda were talking with us about this morning, right? Passed down, as Resma talks about in his work, and living in the body. And so it's important to just contextualize this work with some definitions as we start to have this discussion about historical trauma. So Dr. Karen Walters in 2012 said, an event or series of events perpetrated against a group of people and their environment, namely people who share a specific group identity, with genocidal or ethnocidal intent to systematically eradicate them as a people or eradicate their way of life. Okay, so this is one definition that we offer of historical trauma. Thinking about the key words that are in that definition. Another definition that we offer comes from the National Resource Center for Reaching Underserved Victims. Historical trauma is the cumulative exposure to traumatic events that not only affect the individual exposed, but continue to affect subsequent generations, right? So this is that idea of that trauma that's living in our body, it's being passed down. This is large-scale trauma that's been inflicted deliberately and as part of a system against a group of people who hold a shared identity. And these shared cultural traumas often remain unresolved. They get passed down through generations, and they form aspects of a shared cultural identity that can happen in response to a shared trauma. We've talked a little bit about this idea of epigenetics, right? Epigenetics is the study of how gene expressions can change, essentially turning a gene on or off and be passed down from parent to child. It doesn't actually change the DNA itself, but it changes how the DNA expresses itself. that's a very like simple definition because I'm not a geneticist, so you'll have to do some more research on that. But that's my understanding of it. It's the DNA, different aspects of the DNA turning themselves on and off. So let's look at some aspects of historical trauma in light of our own shared history as folks in Central Ohio, located in this country, in the United States of America, right? So when we think about, for example, anti-Semitism, Jewish survivors of the Holocaust, right? So this is this historical trauma that has happened. And then we continue to see this through line through to today of anti-Semitic rhetoric in public spheres. We've seen violence against Jewish people and cultural sites, even in recent history. And then even in, local and national politics, we've seen neo-Nazis and folks who identify as white supremacists, right, carrying on this tradition of anti-Semitism and violence against the Jewish community. When we look at First Nations people, the cultural and physical genocide of the folks who are indigenous to this land. And we see even in the recent months, we've had lawmakers and mainstream media erasing historical violence against these individuals. We have a lack of resources and adequate medical care. And this is even more pronounced in the COVID-19 crisis, right? So there's disproportionate impacts of COVID-19 in these communities that don't have as much access to adequate medical care. And then we've seen, we had a Supreme Court decision in Oklahoma within the last few months, and we've seen some positive momentum, right, in acknowledging the sovereignty of First Nations people. And then when we saw that happen, there was this immediate public and legislative backlash against that, right? So even when there's forward momentum, there's this sort of whiplash effect happening. We can look at anti-Asian exclusionary policies and rhetoric. We have a long history of this in the United States, reaching back even before the Chinese Exclusion Act. We can see how Asian immigrants have been exploited and excluded. Their contributions to our society have been devalued. And then as we look at this, following this thread forward, right, our former president even referred to this global pandemic as the Kung flu and is perpetuating this violent rhetoric against Asian folks. And that has also led to actual violent attacks against Asian Americans around our country. Probably the most defining group that we see as having experienced historical trauma that is so closely linked to our history as an American nation is the experience of formerly enslaved persons, African Americans with ancestors who experienced race-based chattel slavery, who were taken from their land and then have been throughout our history systematically disenfranchised. And then we see examples happening daily, unfortunately, where we're confronted with images that perpetuate Black death and violence against the Black body, right? And just like Resma talks about in his book, we are experiencing those traumas in our body. It's re-triggering, right? And folks who come with Black bodies are feeling that trauma like it's happening to them. Okay, so we have that trauma living on in the genes of individuals who are just trying to go through the day and do their work and care for their families. And then they're confronted with images of lynching and violence that traumatize their bodies. We have the state perpetrated violence that leads to this feeling of never being safe. I can show one more visual that kind of illustrates how there's this compounding effect. We go from this historical trauma, right? And then we have this transmission through epigenetics into the social construction and the structural racism that people are living inside of today. And those two things together, right? This transmission of historical trauma and the reality, the very real lived experience of racism today, combining together to create this situation where there's a higher frequency of adverse experiences, right? We can look at slavery, policing, mass incarceration, right? We have the history of law enforcement and the broken relationship between law enforcement and people of color in our communities. We see that heritage of policing, and then we look at our students who are spending time in schools where they're walking past police officers in the hallway, right? And then we have this systemic pushing out of students, just like we were talking about, Ms. LaShonda was talking about, how am I going to trust a place that doesn't demonstrate that it is for me, right? So we have students of color in schools that are showing them by the images that they use, the methods they use for teaching, the kinds of behavior that is praised or marginalized. This space isn't for you. And then those students are being pushed out. We have exclusionary discipline practices that is causing students to spend time in school suspension, out of school suspension, right? A student coming to school with their hood up, an administrator says to them, take your hood down, it's disrespectful, right? And then that child is disciplined, spending time in school suspension, then they're in out of school suspension. At that point, the child is like, school is not for me, why am I gonna keep being here, right? And we know that the more likely students are to have experienced that kind of exclusionary discipline vastly increases the likelihood that they're going to have contact with the carceral system, and the impacts of that on their life are very dramatic. Okay, so another thing, you know, that I just want to raise, as we are located here in Central Ohio, where we have a really high new American population, many refugees who have been recently resettled in our community. We're having individuals come to our community who have been living inside of a very traumatic experience for a long time, maybe come with language barriers, and entering school communities that may or may not be equipped to help them learn English or to provide for the very real trauma needs that they have, right? So just considering, what is the history, what's been passed down generationally, and then as we look at the social conditions, what's there that's compounding? And then when we look at the ACEs happening, are we addressing any of the historical or structural conditions that have set the conditions for that adversity? Or are we just addressing the adversity or the consequences of the adversity, right? Like Debbie said, we're treating the disease maybe, but we haven't gone back. How far back can we go? What can we dig into to help us understand and address these things in a more holistic way? The last thing I'll leave you with for now is that when we think about this ACEs pyramid, right, we can tend to only make attention to the way that trauma is transmitted. And the reality is that not only is the experience of trauma passed down, but adaptive skills and resilience are also things that are passed down generationally. So we have resilience builders that arise out of suffering as a response to trauma, that are highly adaptive, that are rich sources of strength. And when we as service providers, educators, those who are working with young people and families, when we can tap into those adaptive skills, those resilience builders that are already there, right? We can do our work in a way that is strengths-based and builds on, instead of takes away from, the beauty and the resilience that is already there.
And so one study, like I mentioned here at the top, with the Philadelphia Urban ACEs study, that kind of tried to quantify some of this in some capacity, because there's a lot of this we know narratively, right? There's a lot of things we're seeing, we can look back at the history, but quantifying it helps us to kind of take that forward and say, here's the black and white of these numbers, right? Of what it is that exists. And so the Philadelphia Urban ACEs study was done in 2012, published in 2013, with about 1,700 participants. And they were, you recall, I mentioned in that first study, in the original study conducted by Drs. Anda and Folletti, primary participants were majority white, correct? In this replication of this study, the respondents were 42% Black, 44% white, and then everybody else identified as other. And so within that study, because of that more diversity, what Philadelphia was aiming to do in this research was to try to see if we could put some quantification to the impact of ACEs in a more urban setting with a more socially and racially diverse population. And so they went back to those original 10 questions. However, they added 5 additional categories of experiencing racism, witnessing violence, felt discrimination, bullying, living in foster care. So those 5 additional questions were added to that original questionnaire. And like I mentioned at the top, right, there's been a lot of replications of the study, and they've all lended similar dose response correlations. The more that you say yes to any of these questions in that 1 to 10, or in this case, 1 to 15, the more likely you are to, right? And then you can fill in the blank with any of those health outcomes and a lot of those social outcomes. But I think you could probably think of a lot more that would probably be tied to these. And what this study and the outcomes they found were, within that, you can go to our next one, Jesse. Thank you. Within those categories, emotional abuse, physical abuse, neglect, household dysfunction, all of those things, there was a higher rate in the Philadelphia Urban ACES study among participants, primarily among Black participants than white participants, than in the Kaiser Permanente study, with the exception of that sexual abuse category and in that emotional neglect category. You can kind of see those. However, in that emotional neglect, those percentages are really, really close, right? And so it kind of points to this correlation between those responses. And then in our next table that we want to share, this one breaks it down in terms of race. And so, oh, I'm sorry, that's the next one. I'll wait till then. But this one is showing us that substance abuse household member, that mentally ill household member, that witnessing domestic violence, and a household member in prison. And again, you're seeing those higher rates across the board on the left-hand side of that Philadelphia Urban ACES study and that survey. And what that's showing us is it's not just about the year it was published. I think that's really interesting on the Philadelphia ACE survey website, where you can kind of dig deep into this and see all of these percentages broken apart and kind of some more about the questions they asked and how they conducted the study and the methodologies. They talk about how they were challenged with, oh, well, you know, it's 2012 versus 1998, so that probably has a lot to do with it. And they push back and they're immediately like, no, these things have always been a thing. And that's exactly the point, right? Is that we need to start confronting that this isn't just a symptom of the time, it's increased awareness now. We know better, so we're trying to do better. It's not that it's not been there. We turned a blind eye to it, or we accepted it because that's just the way things have always been, right? So we just keep on going and pretend it's not there, or don't see it as an issue. Now we're trying to call that to light. And so that's what this study was trying to attempt to do back in 2012. And now we're carrying this forward in 2021, trying to continue those results in terms of making change. So then in this last, this other table I want to share with you, this breaks it apart in terms of respondents. So as I shared, 42% were Black respondents, 44% were white. And so taking those specific respondent demographics and breaking that apart within these 5 categories, here is what you see. Witnessing violence is a really, really, really stark increase, right? Feeling discrimination is also a really, really, really high increase. And so it's really important for us to start to recognize that past experiences shape the brain, shape the body. You heard that in our first session about how we carry these things forward, how that happens intergenerationally, how that happens through epigenetics, how that happens in your own experiences individually, and what you perceive as threats. We talked about that a little bit too. I remember that the Cascade of Fear, I believe, was what it was titled. But those past experiences are what we carry into our day-to-day existence. And it's really pronounced and stark here when we see the difference between these categories of feeling discriminated against or witnessing violence. Those are things that when Joanna talked with us about that, the pyramid, right? Those are those 2 levels of social condition and local context and historical trauma. So as we take this one step further, what I didn't share with you in that first one was the percentage of individuals who answered that they had 1 or more ACE. That was about 2/3 of participants out of that 18,000 said answered that they had 1 or more ACE, so about 66%. In this questionnaire, this replication, 83.2% of those respondents had at least 1 ACE. And then 63% of those adults had a higher ACE score when including the urban ACE items. So what this does for us is demonstrates the possibility of additional stressors found in urban environments. And so this replication was the first of this capacity. And it really led us to some of these things that we're trying to bring here to you today, or things that you probably have seen in practice in other capacities. So how you've seen this maybe come up is last year, Franklin County Public Health declared racism as a public health crisis. And other public health departments in various states have also done similar things. It's been done in, at some state level, but in terms of actual policy or systemic change, we're not seeing that yet, right? But at our local level, our public health board has recognized the same thing you have all recognized in hearing the results of these ACE studies, right? And hearing and seeing the results of this Philadelphia urban ACE studies, like, oh, ACEs are problematic. They're actually the cause and not necessarily the symptoms. But, I'll break that apart to you in just a second. But that's how I kind of tend to think of this, is just, if we're going to start to make these things public, right? We're making a public declaration of racism as a public health crisis. Now we are shifting our perspective, and we're doing it in the public light. At the very end, we're going to talk about how systems kind of are the carriers of making impact and change. But this is a really good example of what that is, because when we finally have departments coming on board that help us to recognize this, it's not just the work of individuals trying to carry this forward anymore, right? It's bodies of organizations, of government levels, of policy change, of all of those domino effect things that can happen once organizations get on board, right? So how does this all tie together? And so this slide, Joanna touched on it a little bit. I want to kind of reiterate it now that we have this additional information. Basically, one of the essential findings of this study is that there is a link between stress, particularly toxic and overwhelming stress, to ongoing health outcomes. But if we aren't paying attention to the right stressors, the right ACEs, then we're going to be missing the link between those ongoing negative physical, behavioral, emotional, and mental health challenges. If we, who have heard a lot about trauma-informed, right, at this point, you've heard it from somewhere, whether it's been us, whether it's from other consultants who do this work, we know what trauma-informed is supposed to mean, right? So if we, the experts, are only paying attention to individual event-based ACEs that can be checked off on a questionnaire, with a yes or a no, then we're going to miss the impact of historical, generational, and social context adversities that are experienced particularly by individuals of color and communities of color. We're missing the underlying adversity that's impacting the ongoing health of people. So again, to me, this kind of diagram is that pyramid just turned on its side a little bit. That the historical trauma that has happened in this nation and geographic location in particular creates that intergenerational transition. It flows to the social context and conditions and structural racism. And then built on top of that leads to the trauma response that we are familiar with. That's the thing we see, right? That's the thing we notice, is the trauma response. But it kind of, we have to go backwards to then move forward. And so when we do this work, as I've said, even in this arena today, ACEs is the understanding of how we were that's the cause, right? But now in my own journey and expanding my own understanding, and hopefully what we're providing for all of you too, is ACEs got us closer to the root cause, but the root cause is actually embedded in that historical trauma and that generational embodiment, which leads to the social conditions, which leads to the ACEs, right? So we got to continue to go back because we're looking for a root cause to do the analysis and not just treating the symptom.
Thanks for that overview and sharing, Debbie. We'll just kind of pause for a second to see if there are any comments or questions about anything. There's a lot to take in here, particularly when we think about the impact of history. And again, referring back to the previous session, the work of Resmaa Menakem certainly challenges us to look at the impact of all of our histories and how that is continuing to be carried forward. I think a lot about in terms of the ACE study, that the initial study and the initial conversation between the doctors and their patients was recognizing that they were only having conversations at this level of intervention, at looking at behaviors that were impacting their health. And doctors and Folletti then had conversations to realize that there was more going on beneath the surface. There was more to the story. And similarly, when we pull back and look at the impact of history, look at then how, as we start to learn our history better, as many of us are having to do, how that plays into the social conditions in the local context. And really, it's the recognition that these ACEs do not just happen in a vacuum for no reason out of nowhere, but there is history, there is local context that plays into it. I think it's, important for us to also just kind of mention that although we're giving some examples, of course, and we're certainly paying a lot of attention to the impact of our American history of chattel slavery, and we're going to say a little bit more of that in a moment, these are not the only examples. Personally, I've been challenged recently to be thinking about some of the historical traumas that we're kind of living through and witnessing in real time. We just celebrated we just kind of honored and recognized the 20th anniversary of the attack of 9/11. And at the same time, then we were watching the collapse of the failed interventions in Afghanistan. And now we have Afghan refugees coming to our city and coming to our nation. That's a real poor summary of a historical trauma that we're witnessing in real time, and that this is really impacting families. And so these are things that perhaps with the benefit of time, we can look back and name things a little bit more clearly, but in the moment, people are experiencing this trauma happening right now. Joanna gave, she mentioned as well kind of immigrants and refugees, and there are, of course, families now at our border who are fleeing persecution and fleeing violence in their home country and cannot find asylum in our country, and are being turned back. And this is a shared trauma that they're experiencing. And for those of us who work in the field, who are working in schools, who are working in treatment locations, we're engaging with the families who this is their shared historical trauma, and how that then plays out in ACEs and that trauma response. So just pause for a second to just kind of breathe before we give a few more examples, a little bit more kind of framing of what this can look like, particularly when we're thinking about the impact on people of color, particularly Black Americans in our communities. So what was interesting is kind of right around the same time, actually before the Kaiser Permanente ACE study was released, there was a professor at the University of Michigan who put out what she termed a weathering hypothesis. And she termed it a kind of toxic stress. Again, it's really kind of fascinating. I think we talk about toxic stress quite a bit now, but we're looking at, I guess I got to do my math here, about 30 years ago, that this idea was brought up of recognizing that there was a toxic stress triggering a premature deterioration on the bodies of African-American women as a consequence of this repeated exposure to this climate of discrimination. So the impact of racism, of the impact of being a person of color in the United States, how that triggers a physiological stress load. And this is the same mechanism that we see in the ACE study, that we recognize that early experiences of adversity and stress lead to a deterioration of those stress response systems. And this kind of hypothesis was put out, particularly the impact on Black bodies and Black individuals. So the stress inherent in living in a race-conscious society that stigmatizes and disadvantages Blacks may cause a disproportionate physiological deterioration, such that a Black individual may show the morbidity and mortality typical of a white individual who's significantly older. And as a person who is a clinician, as a person who is white, and as someone who is, I'm learning about ACEs and thinking about the connection here, as I learned about ACEs and learned about, became trauma informed, recognizing there's more to the story. And my clients are bringing into my office, into my agency, a history that is impacting that interaction. This type of research and this type of framing of this weathering hypothesis reminds me that a person of color coming into my office or coming into my agency already is carrying in a race consciousness that I am unaware of. They are carrying a weathering that I have not had to carry. And that is going to shift my practice and shift how I engage with that individual to create more of, hopefully, of a sense of safety. And I think LaShonda spoke to this really well, really directly in the first session, talking about even just looking at who is present in the space that I'm walking into. And that's an awareness that that is maybe something I've never had to consider before, but I need to recognize that that is a consideration for many of my clients and the young people that I'm serving. Another kind of way that another author has phrased this, Mary Frances Winters phrased this as Black fatigue. That's actually the name of her more recent book. This is an excellent resource that I recommend for folks. And she phrased this as the repeated variations of stress that result in exhaustion, in extreme exhaustion, causing mental, physical, spiritual maladies that are passed down from generation to generation. And so here we have that intergenerational transmission, and we can see that play out in a lot of different ways. Statistically, probably none of this is going to be a surprise to you all. I would recommend the groundwater approach that was developed by the Racial Equity Institute. And they look at this as saying, similar to what Debbie was talking about, the presentations of the symptoms and the diagnoses are simply what's happening on the surface, but then there must be something else going on below the surface. And recognizing that we live in a racially structured society, and that is causing racial inequity. And so when we look at the national data across all various determinants of health, we're seeing consistent inequity. So this is just one example of their work, and we can see how we sort of phrase this as a baseline. If we're looking at infant mortality, if we're looking at academic performance, if we're looking at engagement in a foster care system, and then also financial indicators, we can see that the likelihood of having a bad outcome is significantly higher. It tends to be at least 2 times higher, if not significantly more. And of course, we have this one here of incarceration. Again, we might, kind of think about that as this shared historical trauma that we're living through currently, and having the lens to see that right now is something that takes a lot of reflection to look at. So again, this is probably not necessarily a surprise to anyone, but we're seeing this is sort of the outcome, the parallel. When we look at that initial ACE study, we know that Drs. Anda and Folletti said there was a dose-response correlation, higher likelihood of having these physical, mental, and behavioral health outcomes. And so we're seeing that same dose-response correlation in our work when we look at the impacts of racism in our society. Debbie, any comments or questions that we want to take a second to touch base on before you jump into kind of looking at how this is showing up in the pandemic?
I don't think so. I've been trying to watch the chat here and answering any of our Q&A box questions as we go. Let me scroll back here. We did have one. It says, how do you cultivate others to care and not just see a new story? Afghanistan is a real trauma to innocent people too. And so I thought that was worth answering probably before we move on.
Yeah, great question. And I saw someone ask to put up this chart, so I'll do that real quick. Do you want to respond to that one, Debbie? How do we challenge people to care and not just kind of see it as another story?
I think if we could challenge people to care, we would solve a lot of the problems,
Right.
wouldn't we, in the world?
Right.
Just tell us, Debbie.
Yeah. Guys, I would have a lot of money if I knew the answer to that one. I do think that if we look at it from that brain-based approach, there's always small tolerable doses that we have to work towards, right? And so I think a lot about that in my own personal life of trying to challenge people to see things like Black Lives Matter as different than, well, isn't all lives matter okay, right? And so shifting that is hard, and it challenges me a lot too, to step back and recognize that people are bringing their own past experiences, which are not mine. And I've had to take those conversations in very, very small doses to make change. And it's taken a long time. And I have to have the emotional capacity to do it, right? It isn't my responsibility to teach everybody around me. But if I have the emotional capacity to do it and feel up to it, then I can step into that. But it has to be an invitation, and I have to accept to do that. I can't just be the one put in charge of doing that because I identify I'm a person of color, right? Like I can't be the person. And so I think about that a lot because I think about our controversial topics too, like the war in Afghanistan and all of these, refugees right now who are seeking asylum and from different capacities and a lot of different events that led to that. It's just so overwhelming to break apart, I think.
Debbie, one thing I was thinking about a lot this morning as we were listening to the first presentation too, this is where like Resma's work, I think, is such an interesting answer to this question, because we're used to kind of trying to intellectually answer this question. What can I say to change someone's mind about something? And I think we probably all have had experiences where we know that that doesn't always work and isn't always productive. And so Resma's work really lives in this embodied experience and paying attention to what is happening in my body when I'm having these conversations. How do I stay as a settled presence? And how do I metabolize my body's reaction to having these types of conversations? And then in being a settled presence who is able to have this conversation, we are able to also then settle and harmonize with the bodies around us and help them to be able to have a conversation that elevates their stress response without kind of losing the plot, right? And so it was really new learning for me as I worked through my grandmother's hands to think about having this connection to my own body as being one of the most helpful and transformative things that I could do in my own work around justice. And so I think, if you're interested in that, exploring more of what was brought to us this morning and more of Resma's work is a different kind of approach than I had encountered before, and you may find it helpful.
Debbie, there was one other question, and thanks Joanna and Debbie both for kind of tackling that tough one there. There was one other question about sort of is there kind of an official revised ACE test or ACE questionnaire, and there isn't. There are a lot of replications of it, and so I will post a link in the chat here of the CDC, kind of where they're having the updated various kind of ACE questionnaire outcomes. I would just say briefly, is that we really try to emphasize that the lesson that we take from the ACE study is not that we need to do more ACE questionnaires. It's that we know that this historical trauma and that these social conditions exist. We know that ACEs exist. We know the data is in and the data is consistent. And so we want to take this information to shift our practice to have universal best practice approaches of creating safety for our clients and for the young people who we're working with. But I will still kind of post in the chat there where folks can find updated studies. And Debbie, I think you're going to then jump into this connection to how this is playing out in regards to COVID.
Yeah, absolutely. And there are good comments in the chat too. And we always encourage people, if questions like that come up, we don't claim to be the experts in everything, right? And so we always appreciate new perspective. We appreciate how you've seen this play out in your own work. We appreciate what your experiences and what you are bringing to the table are too. And so when you put those things in the chat about like how you would respond to those questions and those kinds of things, that's helpful to us too. And we all learn collectively. And that's really what our work centers around too, is just collective learning. Rebecca, your comment here, I just really appreciate it. And I want to kind of, it helps me segue into this next section. So thanks for that. I'll send you a 5 later. It says, we need to come to understanding that being present and witness to others' experiences and learning about that experience has nothing to do with my own or negate the experience of others. Exactly right, right? Which kind of leads to this dual pandemic that we're in. And it's not a surprise. We've been here for a minute. You know, we were going to go home for 2 weeks with COVID and then go back to work, and it's been 18 months or something, right? And we're still here. And in some ways, it's much more intense than it was at the beginning, depending on who you are. In conjunction with that, systemic racism is alive and well, and unfortunately for all of us. And so it's just the living in between all of these experiences and having to show up can be very, very exhausting. And so I really resonate with that quote. And so as we move into this next section of context, we want to kind of layer this on top of everything we've talked about so far. So as I just mentioned, the COVID-19 pandemic, as well as with marginalized groups, there's a lot of things going on, not just with systemic racism towards a specific group of individuals, right? There's racism happening across the board in a lot of context, and there's a lot of marginalization for other groups like the LGBTQIA+ community. There's, you know, for the transgender community, there's just a lot of things happening on top of the COVID-19 pandemic, and something that kind of is in the corner, but pushes a lot of that forward in some ways, in a way that's sensationalized, in some ways in a way that is completely accurate, depending on what it is you're seeing, is media. That's social media. That's media in the form of your radio, your TV. That's media that you are reading on your news. If you get that notification or banner that pops up with the news clips you have to hear today, or the news stories you must see today, right, and read about. All of those things tend to stack on top of each other in a way that can be really, really overwhelming. And recognizing that for some folks, there's a need to step away, but there's not really anywhere to go with it, right? And so I tend to tell this story here from the beginning of the pandemic, when COVID was just starting and we really weren't sure what was happening, and we were trying our best to be safe, and we're putting on our masks to go out into the community. My partner, my spouse, who is a Black male, also had a conversation with me one night about his fears about this pandemic. And his fears weren't necessarily rooted in the coronavirus itself. It was how his putting on a mask would be perceived to others. And so as a Black male, and we're sitting here having this conversation, he says, Debbie, I want to stay alive, but I want to stay alive. And if I put on a mask, how will I be perceived? I don't want to be perceived as a threat walking into a grocery store with a mask on my face. But if I don't put it on, I'm at risk of catching this virus that I don't know what it's going to do to me. I don't know what it's going to do to our children. I don't know what it's going to, cause for our families. I want to stay alive, but I want to stay alive, right? We're 18 months into this pandemic now. Systemic racism hasn't gotten any better, and COVID-19 hasn't gotten any better. And the fear still exists for people who identify in those marginalized groups. We're fighting a dual pandemic daily when we wake up. And that's where we're living, in this constant state of fear, both of what's happening medically, but also what's happening to groups who are marginalized, groups who are perceived threats, groups who are perceived as intimidating, based on lots of stereotypes and lots of other perpetuations of a type of person. Based on those biases you heard in that first section about biases. We all have them, but some of us have them greater than others. And depending on how negative or large those fears loom for us and those biases are for us, we may not react in the best way. Violence can occur based on a reaction based on an implicit bias. And that's what my husband meant by saying, I want to stay alive, but I want to stay alive. Somebody's reaction could take my life away in a second. So what's the thing I pick at the end of the day? And so we had a really honest conversation about that, and it's one we continue to come back to. And so as we think about this pandemic, you've probably heard this term and this phrase. It's one we continue to say and come back to, and that we are all in the same storm, but we are not in the same boat. And our boat is shaped by what resources we have available to us, the size, the condition of the boat, and all of those things are all based on the things that we have access to. And it's important for us to recognize that some people have more access to those resources than others. There's a privilege there that is identified that helps to shape the size, the condition, but also based on our past experiences, our ability to weather the storm is rooted in those things. And if I don't have as much of that, then my ability to weather the storm is a lot less, and I'm feeling really tired about it. And so as we think about we're 18 months in and things aren't improving, we need to continue to recognize, because that was a really big push at the beginning, right? Was we're all in this together. We're all in this together. We have each other's backs. And then there was the recognition of this. We're in the same storm, but we're not in the same boat. And so there was a lot of solidarity there at first. I challenge you to remember that this isn't a sprint, it's a marathon. And people are still living in this storm, trying to weather it. And the condition of their boat is decreasing and becoming very weathered as well. So we just have to keep those things in mind. To throw a little bit of statistic onto this, right? These things aren't going to be surprising to see. But that risk of COVID-19 infection, that hospitalization broken apart by race and ethnicity, you've got cases, hospitalizations, and death there. And you see the increased percentages across the board for those various marginalized groups. So to summarize all of that, right there at the bottom, Blacks, Latinx, and Pacific Islanders at least 2 times as likely to die from COVID-19. And there's a lot of things attached to that too, right? There's a lot of reasons why, which I'm going to do in a couple of slides, but we wanted to throw these statistics out because they're not surprising, but they're overwhelming. They're saddening, they're disheartening, and it highlights and amplifies the problem that it is we're trying to address. To bring this locally to our own community, there's an interactive map that you can utilize. We've got this on this slide. We'll try to copy paste it into the chat too so people can take a look at it. But what this does is it's an interactive map where you can kind of bring it down to your local level and see what those cases are. And I don't remember when we pulled this data, Jesse, it might be a little bit outdated, but I think the map still works, right?
Mm-hmm. Yeah, it was, yeah, I mean, sadly, again, this is going on so long, this was about a year ago that we initially pulled some of these numbers. So I'm not sure if this particular site is still pulling the same data.
Yeah, I did play with the map yesterday, maybe the day before, sometime in this, I can't keep track of time anymore either. That's a COVID side effect, it feels like. But this interactive map still works, and there's still an ability to kind of look at those things. So we'll get the updated version of that. But what you see here, even a year ago, is these statistics and how broken apart that is in terms of what those cases versus the cases per 10,000 are. And again, not surprising, but a little bit disheartening to see that. And the reasons why are still prevalent 18 months later, in that these marginalized communities often hold these essential worker populations. They're the people who are going to work. So when a lot of us were ordered to stay home, some of us couldn't. And as we broke that apart, most of those individuals who had to go to those essential jobs were members of those marginalized groups, which brings us all the way back, it feels like, to that historical trauma and those intergenerational events, and all the way back to chattel slavery and the opportunities people have had, right? Because of the time attached to them and how long those things went on for decreases the opportunity to come out of some of those local conditions.
Debbie, I think this is a good place for us to think about for us that are, kind of working in the field, and then we have the opportunity to structure how we provide services. We're finding that actually providing remote services increases accessibility and increases safety for some of our populations and for some of our clients. I guess just this slide kind of, challenges me thinking about what do we determine to be an essential worker position? What do we determine in the mental health field to be something where we have to be face-to-face? What are the time constraints? What are the locality constraints? And what opportunities do we have to shift some of the underlying systems to increase accessibility and to increase safety? And how might that be available, for people in different ways? And I think actually there's probably a lot of folks at the Mental Health America of Ohio team who are doing that work to try to figure out how do we increase accessibility for our clients who need that. But those are some of the things that are potentially within our power to make some changes around. Joanna, do you just want to touch base real quick about the impact on education?
Sure. Yeah, I think, we know that the experiences of young people in schools over the course of the pandemic has varied widely, right? And there's definitely an argument to be made that it's not very helpful to frame this conversation as like learning loss or falling behind, because we know that, just getting through this pandemic to the point that we are now, attending to our own mental health needs, students and young people are showing tremendous resilience, even just in getting to the point that we're at now. But we can see when we look at some of the data, some differences in outcomes for students of color as compared to their white peers. And this widening discrepancy is a cause for concern. The data on this graphic is almost a year old now, and I'm sure there's going to come out soon updated information from the 2020-2021 school year. But when we look at this particular chart, right, the blue dots represent schools with greater than 50% white students, and the black dots represent schools with greater than 50% students of color. And we can see that there's almost a 10-point gap in most of these grade levels and subject areas when considering the amount of material that students have been given access to learn in the 2019-2020 school year. So, we wonder why this is happening, and there's going to have to be many, many more studies done to try to help us parse what has happened here and how we can and do it better when things like this occur in the future. But we do know a few things. Anecdotally, as a person who lives and works in Central Ohio, I work in a school district that's a slightly more suburban school district, and my son goes to Columbus City schools. And so I have had the experience of watching suburban school districts being able to return to school sooner, having their students have more face time with teachers, whereas Columbus City school students were home pretty much all of last year. My son is returning to school as a second grader, having never had a full year of FaceTime with his teacher in his academic career, right? And it's not a value statement. Potentially this was the right call to keep students from CCS home and keep them safe. But what we do know is that hybrid and remote learning options mean less FaceTime with the teacher, and have accounted for some reversion to those very traditional non-student centered ways of teaching. I give you the information, you give it back to me, right? Because we're sort of locked into these, what happens when we're in our stress response, we're just teaching in a sort of default way. We don't have that live access to teachers to coax our thinking further. And we know that it takes a remarkably high level of self-motivation and self-management, right, to be able to be fully independent in the learning process without a teacher helping you through that. Most kids, myself included when I was in high school, right, needed access to a teacher in order to do our best learning. So as we move forward through the hopefully end of this pandemic at some point, and as schools are able to be more in session, more full-time, looking at this gap is something we need to consider and think about how are we being thoughtful in the way that we message this to students, that it's not that they're behind and that they've done something wrong, but also what work is being done to counteract this achievement gap that we already know has existed historically. One thing we talk about on our team a lot is, wouldn't it be great if this is an opportunity for a creative imagining about what success looks like, about what value is placed to certain sort of arbitrary markers of academic success. But we've seen students and communities be so strong and so resilient through this whole experience, and how are we honoring that as well, even if it doesn't fit into what we've traditionally considered to be success in school?
Yeah, and I just want to make sure, we're clear that these are, this is data from at a national level, but it is just meant to be, kind of representative, again, what we're seeing, anecdotally and in our community as well. And we could, spend days looking at how this plays out in different settings, really kind of to just reiterate what we learn from the adverse childhood experience study and what we learn from expanding our understanding of the ACE pyramid. Again, when we before we knew about adverse childhood experiences, we were only engaging with clients at the point of the adoption of those risky behaviors, as the adoption of behaviors that were creating challenges in their life. And we assumed that the behaviors were a choice, and we assumed that we treated them as moral decisions or individual choices. And then we learned that there was more going on, and that experiences from childhood shaped the stress response system. Experiences from childhood impacted the brain, impacted the body. And now we are continuing to grow and learn and make the connection that the local context and the history plays into those experiences of adversity, and those are not happening in a vacuum. So thinking particularly around school, of course, school is incredibly localized. It's incredibly localized in terms of the neighborhood, the economy, and how that's connected to funding. But we also know that it doesn't have to be this way, that we have opportunities to shape and impact and direct how those, particularly how those local context settings are going to present themselves for more opportunities and be more responsive and supportive for all of our clients, for all of the people in our communities, and that we are then taking into account what the historical trauma, what the historical experiences are, and what that generational embodiment of that is going to look like. So really kind of the main takeaway here is recognizing that there is more to the story. There is more going on beneath the surface. And as a mental health provider, as a service provider in the community, as someone who may be working in schools or in community mental health, I have to take that into account in how I am shaping my programs, shaping my services, shaping the context that clients are engaging with me, to have that be as supportive and safe as possible. Of course, when we do this kind of work in regards to trauma-informed care and trauma-competent care, we focus a lot on the trauma, and this has been a lot of focusing on the negative here. But it's so important to point out that ACEs are not destiny, and it's really, really important to look at this as those of us who are coming into this work, who are white and who are living in white bodies, to really check myself that I do not adopt a deficit mindset mentality. So every time I see a person of color, I'm thinking, oh boy, that's so terrible. Their life has been so awful. Things must be so bad. And boy, it is so tough to talk about racism and talk about being a person of color. To only focus on the negative is to take on that deficit mindset. And we really want to take the opportunity here, although it's incredibly important for us to recognize the impact of historical trauma, it is even just as important, and perhaps more important, to recognize that there are always resilience factors at play. Anytime there is adversity, there are always resilience factors. There is going to be the challenge, and then there's going to be the response. And as a practitioner, as someone working in the field, my job is to do my work ahead of time to recognize the impact of the historical trauma, and then in my day-to-day work with my clients to be looking for identifying the protective factors that are already at play, that are bringing that individual into my office, that are serving and supporting and leading that individual to be successful and to have an impact in the work that they're doing. So we're going to shift here and talk a little bit more about these resilience protective factors because they are there. And here's kind of the other shift. Just like I have to expand my understanding of what ACEs means, if I'm only looking for ACEs in that 10-point questionnaire limited lens, I'm going to miss a lot of the adversity that's taken place. If I am only looking for resilience through a white supremacist, Western guided framework, I am going to miss quite a lot of resilience that is happening in ways that might be outside my previous experience. So let's talk a little bit about what we mean by resilience. This is a word that gets thrown around quite a bit in quite a lot of different ways. You may even hear about a resilient economy. You might hear about a resilient school system. You might hear about trees or plants being resilient. And they're really kind of talking about this bouncing back, this response to the adversity. We have sort of landed on these 5 general categories around resilience and thinking about connections to community. Of course, it's about relationships, but it's also about identity. It's also about when we think about connections to community, there's some deep culture there. Who is my family? Not just my biological family, but my extended family, my chosen family. Who are the people that I spend my holidays with and my time with? Who are the people who are in my home and who are in my life? And so as I'm connected with those people and I'm facing challenges, what are the moments of success that I see that then give me a sense of hope to move forward, a sense of hope to believe tomorrow is not necessarily going to be just like today, that there is hope for the future and there is a reason to continue to push on. And that then leads into this perseverance that I'm not going to give up. All of this then gets rooted in self-regulation, which is the adaptive and appropriate response to stress. Now, we have kind of here in the middle that activating one of these starts this positive cycle. They are very much interconnected with one another. And as we activate one resilience factor, we see others start to connect as well. And I will just kind of throw out that probably, I like to say this a lot, that within all of this, particularly as we're talking about ACEs and resilience from a multi-diversity, cross-cultural lens, whatever kind of term we want to throw out there, what's really key to think about for me as a service provider and practitioner is activating my curiosity and saying, okay, well, tell me a little bit more about what's going on. Tell me about why you're here today. Tell me about somebody who's important in your life, who supported you to get here today. Or perhaps who is important in your life and why are you choosing to do this work now? For many of our clients who we're serving, they are choosing to get help for themselves so that they can help other people in their life who are important to them. And when I can learn about that, and get curious about that, now I can see what some of those resilience factors are and how that might be at play in their life. Joanna, these are a couple of things that you pulled up. Do you want to talk about this slide?
Sure, yeah. So these are a couple of the resilience factors that Jesse talked about. And I've just pulled some quotes from some key folks that I think kind of shed some light on this. So we think about connection to community, right? This quote from Angela Davis, it's in collectivities that we find reservoirs of hope and optimism. And I think there's so many great examples, and you can drop some examples in the chat of where you see that happening in melanated communities and communities of color or other communities that exist in the margins. Some examples I can think of, we've seen a lot of collectivism emerge in the pandemic, some of these like local networks for providing support, Black sororities and fraternities and social organizations that provide that sense of connection to community and support. Black churches are a really good example of this. Immigrant communities, new American communities in Columbus, we have the opportunity to see this happening a lot as new folks come, that the existing network of resettled refugees is able to connect them to work and employment and other kinds of support. I like this quote from Vice President Kamala Harris about moments of success. To the little girls watching, dream with ambition, lead with conviction, and see yourself in a way that others may not, simply because they've never seen it before. Know that we will applaud you every step of the way. And I think, this sense of celebration is something. I am a white-bodied person. I am firmly part of white American culture. And I think sometimes we don't celebrate as hard and we don't have as much of a connection to how we can loudly and raucously support one another. And I have been very lucky to be the teacher many times of students who don't share my same racial identity markers, and watching my students graduate, and the way that their families have celebrated them and the success that they experience has been really inspirational to me in terms of just like convicting and like, do I let myself experience joy at that level? Thinking about, you know, rites of passage and how important it is to see ourselves represented in mainstream media. I know Jesse has a story he likes to tell about Simone Biles. When we think about like how powerful it is to see ourselves and each of the different identities that we may hold represented and being successful, and what it looks like to celebrate others and have ourselves celebrated. And I know there was a conversation in the chat happening a little bit around the idea of self-regulation and how important it is for learning. And that's where a lot of my work lives. But I love this quote from Maya Angelou: everything in the universe has a rhythm, everything dances. And so often, you know, in our classrooms, we see very static, right? Sitting in chairs, maybe in rows, listening to a teacher. And we have this idea that that's what learning looks like. And yet when we consider historically how many cultures have taught all their major life lessons through rhythm and dance and this sense of collective connection to one another, and that learning is as valid and potentially more valid and effective than the way that we think about school now. And so thinking about how we tap into that sense of rhythm, that sense of connection to one another through music, through song, how it feels when you hear music that you're culturally connected to, or you eat the food of your homeland, that sense of connectedness is kind of what we want you to take away from that idea.
Yeah, Joanna, you know, you talked about how our classrooms are static and we think learning only happens when we're sitting up straight in our chair. We absolutely have that template pushed on us that that's what therapy looks like, and that is what counseling looks like. And that really an effective or proper counseling session is one where we're simply sitting and talking to one another. But when we can bring in rhythm and movement into therapy and into counseling, you know, that is really that's where some healing takes place. And that rhythm and that movement, particularly when we start to look at the impact across human history, there's a lot happening there for sure. You know, just kind of one, we'll give a couple of specific examples of here, because again, the shift here, we're talking broadly about how do we understand and know that historical trauma, social context, intergenerational trauma plays a role, but then how does that impact my day-to-day work? My role is to expand my lens to see where is resilience showing up in ways that I would not have anticipated. Where is resilience showing up in a way that for me, that actually doesn't, you know, land with my experience, but for this individual, it is absolutely resilience. And how can I continue to honor, to affirm, and to encourage that? And Joanna mentioned, you know, that a learning experience for me was in seeing some online conversation about how Simone Biles was supporting her teammates. And as a white man, my hair doesn't mean a lot to me. But online, there was some conversation across Twitter where they said, for some folks, seeing Simone Biles do the hair of her teammates just looks like preparing for the next event. But for young girls of color, for young Black girls, they see this as a rite of passage. And what's fascinating to me is when then I did a little bit of research into this and just kind of typed a few things into Google, there was, many of you will not be surprised, but I was, again, these are things that I am not particularly attuned to as a white man, but there was a cascade of articles of critiquing Simone Biles's hair. And that apparently this has been a conversation online for years. And so for me to shift and be aware in my understanding that for many of us, we know now that hair, particularly for Black girls, hair is very important culturally and has been a source of historical trauma. We know, thankfully, in Columbus, we have the Crown Act, but even if we have things written down in policies, doesn't mean that that always plays out in our classrooms or in our communities. So for me to expand my lens and see that connecting around hair is a source of connection, is a source of resilience, is a source of strength. I wouldn't have identified that. I wouldn't have seen that but I have to, just as I expand my lens around adversity, to expand my lens to see the resilience that's happening. Debbie, did you want to touch base on systems real quick? And then I know we're reaching the end of our time, so we want to make sure we have, we want to open up for some questions as well.
I do. You know, this is my favorite topic, so I'm going to try to keep this as condensed as I possibly can. But if you've been in trainings with us before, you've heard me get on the soapbox. I won't get too in depth, but there was a comment in the chat about the word resilience. And it says, I've struggled existentially about resilience and how we're handling the conversation. While it's great for survival, it's almost as if we are praising certain populations for their ability to withstand pain. 100% agree. And what this slide represents and what the next one we'll kind of talk through is how if we simply teach skills of resilience to individuals, we work on those 5 things, right? And we amp those up for those individuals, but then we put them back into the world, into systems of trauma that have harmed them, we are not doing the work. It's a circular movement, right? It's that individual skills of resilience and then those large support scale systems on the top. And my work lives in policy. And that's what I'm talking about. We can't just do the work from the ground up. It has to come from the top down too, so we somewhat meet in the middle. Otherwise, we're running on a hamster wheel, because when the circle falls apart, we're not helping, right? This is internally and externally. I'm talking about internally within your organizations that you work with and for the clients that you serve. When we talk about these topics, we tend to think, how do I do this better for my clients? How do I do this better in my work? How do I do this better as a professional? But we fail to stop and recognize if our workplace is a trauma competent agency, an agency that stands for anti-racist practices, and an agency that outwardly puts out that they're against oppression, and they're going to fix the policies and procedures that are harmful, right? Now that's at a local level. You can take that to the state, you can take that to the executive branches of the government and talk about the policies that exist, zero tolerance policies. I'm not going to get into all of them, but that's a quick example. But really what the highlight is here is we can't just do the work in giving individual skills of resilience, because it leads to this quote, Jesse briefly put it up, but it says, I don't need you to praise me for my resilience. I need you to stop creating spaces of trauma where being resilient is all I'm allowed to be. It's big. It's big. And Omalara has a lot of really, really great work and really great interviews that expand on this in a lot of capacities. I'll try to find a link here real quick as we're doing some Q&A and share that work with you. But this quote is everything, right? It's not about the individual. If we just say, good job, I'm so sorry you're going through something real tough, get back out there. Right? That goes back to that kind of pull yourself up by your bootstraps mentality, which is exactly what we are fighting against. Resiliency is more than that. Resiliency is not just how you take those things into battle, but it's how you take those things through life in a system that is accepting also and also making those changes. Resiliency applies to systems just as much as individuals. So I'm a step off of it. I know I can go on that for a really long time. So I do want to make sure that we allow time for questions.
Yeah, I think this is a good place that we could pause. And so if folks have questions, they can put those in the Q&A section or in the chat. And as we're waiting, because we've sort of touched base on a few of them as they've come along, but you know, I think the work for us again is to do that homework, to recognize the underlying issues that are in place. The work is not, for me as a clinician, as a service provider, to ask my clients, who may be people of color or maybe an individual who experienced historical trauma, to tell me all about their historical trauma. That's not the next step. The next step is not to say, hey, I took this great training about historical trauma. Tell me about all the things that happened to you and all of your ancestors. My work, I have to come in with that understanding and that awareness. And now I'm going to shift my practice and combine that with the work that we learned about in the first session from Resma Medicum. How do I hold myself and hold that space that presents safety, that allows for agency, autonomy, control, respect, cultural responsiveness for my client, recognizing and knowing that just for them to show up to trust treatment, to trust counseling, to trust a mental health care provider, to trust the system is in and of itself a big step, and that I want to honor and to hold that for them in a safe way.
Yeah, there was a question earlier about language and about how you decide whether to use people of color, Black, or as Dr. Kennedy was using in the previous session, melanated bodies, right? And I think this is related, Jesse, to what you were talking about, right? We can do our own work to prepare, and then we hold the things that we learn and the positions that we take loosely and are open to correction, right? So we do what we can to prepare for the situation so that we don't re-traumatize or cause harm in as many ways as we can. And then when we are corrected, when something is offered to us, hey, when you used that language, it didn't feel right to me, it didn't feel good in my body. Then we take that in and we say, wow, thank you so much for offering that. How can I repair this? And how can I do better moving forward, right? And so it has to do with language, it has to do with our approach, and when we are engaging with people, we don't need to ask people to tell us everything, and then we can do our own work to show up prepared, but then we also understand that doing that work doesn't make us experts, doesn't make us the people who can tell someone else about how they should identify or what their lived experiences are, but we hold all of that learning loosely and open to correction and open to expansion, because people have a wide variety of experiences and we can learn from all of them. We can widen our perspective and our understanding.
Yeah, thanks, Joanna. Good question here about, is the ACE test or is the ACE questionnaire, is it made to understand our trauma or more to be a comparison to our counterparts? So it can provide a little bit of clarity around that initially the ACE questionnaire, back again, the original study was meant to ask, is there a correlation between early childhood adversity and long-term health outcomes? And they found that there was that dose response correlation, that experiences early in life had an impact on the physiology, on the body of patients, and on behavioral health outcomes moving forward. So how that gets played out and the implications, some folks do find that making that connection is very helpful for them. Many clients will learn about the ACE study, and that will help them to connect some dots and to provide a little bit of a sense of why, and that can be very helpful. I think the bigger impact for us to think about as practitioners and clinicians is recognizing that the vast majority of our clients have adverse childhood experiences, and particularly when we expand our understanding of ACEs, there are other factors at play. And so that challenges us to shift our work to increase safety, to increase client sense of control and autonomy, and to work in a culturally responsive way as much as possible. Got a couple minutes here if there are any other questions that folks want to put into the chat area. Debbie just put in some links and information there as well. With that being the case, we would just give you a couple of reflection questions to think about as we move into lunch. Who have been resilience builders in your life, and where are you seeing resilience in your daily life? That might be for you personally, that might be professionally, that might be with your family, with your community, as we look to see how are people activating their resilience and leaning on others to respond to adversity. And then this second kind of set of questions of thinking about how can we expand our understanding of resilience to include intergenerational experiences, cross-cultural, multicultural expressions. And so thinking about what does that look like in settings that maybe I hadn't previously anticipated or hadn't previously looked for. We, again, just really want to express our deep gratitude to you all for your time, for your engagement, for your participation. A lot of great learning happening today. This is a great learning community, and please continue to connect with one another for resources and support. This is absolutely not a one and done type situation. This is a journey. This is a process. We're continuing to learn together, and we're grateful for the opportunity to present and share and to learn alongside all of you and to partner in this work as we move forward.
Thank you to the BBL team, Jesse, Debbie, and Joanna, for that informative, insightful presentation that I'm sure offered everyone a lot of takeaways. Such useful information on ACEs and the higher frequency of the impact of historical trauma and racial toxic stress on adverse childhood experiences, on resiliency, and even on lifespan, and the need to stop creating spaces of trauma.